Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by Village MD, primary care physicians, practice medicine the way you've always wanted, data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, welcome to Working Smarter. I'm Wendy Rubis, General Counsel of Village MD. I'm here today with Janessa Nelson. Janessa, how are you?
Hi, good. Thanks for having me back.
And today we have a new episode of The Scoop. We like to call it The Scoop whenever we're talking about enforcement. We've got some enforcement to share today.
Yeah, we've been seeing some activity recently, Wendy, and it's paused a lot in 2020. Do you know the reason why?
Well, there's a couple of things that are really interesting going on right now. And the first thing is that during COVID, enforcement really was on a reprieve. And in part, that was because courts were really not in session as much, and there was many delays in cases for obvious reasons. And also, just because of the healthcare crisis, all audit activity really ceased during COVID. And so we had a long period of quiet, really, in enforcement. What I've noticed in the last, I really feel like it's been 30 to 60 days. It feels like a change. Is it's kind of like we're back, and so we're seeing a lot more activity. At the same time, of course, we have a new administration. Cabinet members have now been appointed, and they're starting to put out their priorities, and we're seeing activity there as well. And so those two factors are coming together, and that's really why we're back with The Scoop at this time.
Yeah, so maybe we should level set and give some background to our listeners. There's a lot of different federal agencies that are involved in these enforcement cases. So can we talk about how they're different, how they work together, and what we typically see related to this?
It does get confusing. And so we sort of call it the enforcement sandwich because there's a number of different avenues that these cases can emerge. So the first is the Department of Health and Human Services Office of Inspector General. And they do a number of different audits and reports. Many times, if they do an audit, they can find an overpayment, and then they refer that to CMS. So that does become an actual overpayment, but that part is enforced by CMS. One thing that's very controversial we'll talk about later is many times you see extrapolation in those cases. Another totally different world of enforcement is from the DOJ, and that's really obviously the judicial branch. So these are court cases. Often these emerge from a whistleblower, although as we heard from Linda Wazinski in our recent podcast, that is starting to change. But those go through a court process. We know that can include criminal charges and personal charges, which isn't really the case with the OIG. In addition, CMS has a number of different audit programs that reach out to physicians. Here at Village, we do a monthly compliance newsletter, and we were just kind of going through recently the different kinds. But the main thing to know is they can come from contractors or different types of payment reviews. More and more of this is getting sophisticated and based on data, which is actually a good thing in a lot of ways because you get feedback a lot more real time. And then lastly, of course, in Medicare Advantage, payers are required to do their own procedures as they sort of step into the shoes and administer Medicare dollars. And so many times they'll do audits as well. So there are a number of pathways where these kinds of matters, in particular Medicare Advantage matters, can originate.
Got it. That was a helpful explanation. Maybe we should talk a little bit about what we're seeing from the DOJ. We had a great podcast with Linda Wazinski, who shared some light on that. But maybe if someone didn't listen to that episode, what are the highlights?
Well, every year the DOJ puts out a report. It's kind of like a corporate responsibility report in a way. It's kind of like a year in review. Here's what we did this year. So we do have the report from 2020. We know that $2.2 billion was recovered from fraud and false claims, and 83% of that is from healthcare. That number is slightly down, likely due to the pandemic. Interestingly, we have numbers of cases, and we've got a chart if you're watching along, and you can see that the number of whistleblower cases was up significantly, which is interesting because whistleblowers were sort of in the news during the year. And we had a lot of mixed messages coming from the federal government on whistleblowers. But anyway, we had 13 a week on false and fraud and false claims, which is just astounding. But in addition to that, we heard from Linda Wazinski, and we can see in the data as well, DOJ is initiating many of their own cases more than ever. For many years, if you're looking at this chart, you can see for many
the last
years,
10 years, yeah.
Really this almost enforced itself, and very little effort was made to go out and initiate cases. Well, that's changing now. And the DOJ told us on our podcast, and they've said in other forums publicly, agents have their own set of data, and they can find their own patterns and bring their own cases directly out of those data packets. And so that's just a major change. We know that the tactics and methods that they're using include special enforcement units, and we're seeing, and they're telling us that they've got those for COVID-19, also elder abuse, and of course there's a lot of activity going on around opioid abuse. But they also have these rapid response teams which mobilize quickly on a special project, and we're seeing a lot of that in telemedicine, lots of telemedicine enforcement and abuse for obvious reasons. But a new thing that we've seen in the last year or two is cases on electronic health records, where some of the major big brand names have had penalties. So we'd like to hear from our listeners. If you want more detail about those electronic health records cases, send us a note or give us a message on LinkedIn and let us know if you'd like to hear about those cases. Janessa, what's the email?
They can email Sharon@villagemd.com. So Wendy, we've done a previous podcast on the MA enforcement where we talked about 3 cases. I believe 2 are still ongoing. I think that we should just remind listeners that they're watching these, right?
So the DOJ, as we said, that's a judicial enforcement. We've got a couple cases to watch here. They were brought in 2020. They're still pending. There's a lot of procedural things going on, motion practice, venue, jurisdiction, et cetera. So not a lot of development there. The main thing to take away from these cases is that if you're doing audits, natural language processing or other automated audits, you have to be careful that your protocols that you're using are making adjustments for what you find up and down. It's not just an effort to, paste on codes. And when you find things that are wrong, you have to fix them. And most of these cases, as I said, come from whistleblowers. And so, we always talk about listening to your people if they have concerns. One thing to note is we've also got on here, there's a medical group that had a case. That's a little bit unusual. We usually see these cases going directly to payers, but basically what they're telling us is if a medical group, has practices that they know are wrong and they're basically juicing their codes, the DOJ will join a case or go after a medical group directly. So that's kind of been a question for some time. And that's been made clear from this Beaver Medical Group case.
Great. So we talked about the DOJ. Let's talk about what we're seeing from OIG, because they recently released their enforcement priorities in April. So Wendy, what were we expecting these, or is there anything on here that we didn't expect?
Yeah, this is really interesting. We just got these in April. We have a new, obviously, Secretary of the Department of Health and Human Services. First time in history, I think. He's not a physician, and he's actually a litigator, and he's got a record of very aggressive enforcement. So it's going to be interesting to watch. When I look at these priorities, there's a lot on here we were expecting. You see COVID enforcement, telehealth, I mentioned already. We know there's tons and tons of activity around opioid and substance abuse fraud, and also Medicare Advantage Enforcement, which really isn't a surprise. This was on the OIG work plan. We've been hearing for some time that this was really going to start to ramp up just because so many more patients and there's so much more activity moving to Medicare Advantage. What is surprising about this plan, there are some things in here that are new or a little bit unexpected. Patient safety in nursing homes is a priority, which I think we could surmise maybe comes from what happened with COVID. Advancing health equities is on here. And really, I can't think of a time in my career where I've seen that as a priority. I interpret this to mean they're going to be looking at Medicare and Medicaid programs to make sure that they're equitable, not so much at providers. Modernizing compliance guidance, which is welcome. And I would tell the OIG, if you're listening, My name is Wendy Rubis. I would be more than happy to participate in the modernizing compliance guidance. Looks like they're going to be looking for guidance from industry, so I'm raising my hand. But also cybersecurity is on here, which is a little new. We know that we have always had cybersecurity rules, but the idea that the OIG is going to be targeting people who aren't prepared is new. And the information blocking really surprised me. That's a new rule. We've got a podcast on it. I didn't expect to see that as an enforcement priority during this year. But that's really an overview of where the OIG is going.
OIG has announced that they're going to be releasing the results of several different audits throughout this year. Wendy, is it 7 to 9? Is that what we've heard? Is that
We're
correct?
expecting to see 7 to 9.
Yeah.
They've released 4 so far, and I think we're going to talk about 3 of them today that are kind of useful in terms of, what we're looking at on these is what can we learn and enhance our own program to make sure that we're staying on top of where enforcement is. And so that's really why we like to look at these.
Great. So let's start with in chronological order. The first one that we got in February, I believe that this is with Blue Cross Blue Shield of Michigan. Is that correct?
Yes. So this was an audit in February. This was the first one they published. This was an audit of high-risk codes.
So Wendy, what does that mean? They only looked at specific codes, or they only looked at specific charts? Can you clarify?
That's a good question. They described a process that they went through in order to determine high-risk codes. By the way, these high-risk codes are not a surprise. We've already known that these are considered, by high risk, I mean high error. These are likely to be an error, or they're subject to misunderstanding or even abuse. Okay. But they did have a process that they used to determine that. And then what they did is they determined a statistically valid sample of just these codes. So they didn't pull all charts. They only looked at charts with these codes.
Got it. I think that's helpful for everybody to know.
And we're going to put them in 2 buckets. Okay. There's a couple of types of codes that really are, the reason they're high error is because they describe an acute condition. You'd be unlikely to have that condition unless you're in the hospital. Okay. That's acute stroke and acute heart attack. And so the error that they're defining is, and this is interesting to kind of think about what they're doing, is they're saying you have this code, but that beneficiary was not in the hospital. There was no corresponding hospital claim. And so as a result, we assume it's an error. Okay. That's the acute conditions bucket. Then we have this other bucket, which is really, we have this code, but there's no evidence that they were treated for this. And so basically these are, this is my words, not the OIG, but basically the condition is coded as too severe, or there's no evidence of the condition. And that is an embolism, a vascular claudication, and major depressive disorder.
A lot of that comes around them not being prescribed medication, it looked like. So they were looking at the medication list and saying, well, you're not actually treating via medicine for this condition.
Yes. So one interesting thing, if we could say, is on the major depressive disorder as an example, not only does it say it wasn't ordered, but it says that the medication wasn't dispensed, which of course, many times physicians don't actually know that, whether that was dispensed. I don't know how a plan would say, well, the physician in a face-to-face visit diagnosed this, but they didn't get a medication. So that's a little bit surprising to see that. But this is basically under a category of diagnosed but not treated. So they think that these are overstated conditions. So what you see here is the sample size was 248.
There were 188 errors, which is a 75% error rate, by the way. That's really high.
Yeah, it's really high. The OIG recommended repayment of that money. They also recommended that that this particular party go back and identify other high-risk diagnoses that were in this report that were for other periods. So this was an audit period for, a defined year. They suggested now that you know you have this problem, you need to go to other periods and do that as well. And then finally improve your compliance program. And so in this case, the party being audited did not actually dispute the finding.
So Wendy, how do you get from 188 errors to $14.5 million?
Great question. And the answer is the sad, sorry math of extrapolation. And so what that means is an error rate is determined, and then it's applied to an entire body of claims over a period of time. So they don't review each and every one, but they apply an error rate across a body of claims. And so this is very high on the pain scale because it raises the stakes exponentially. It means that if you disagree on 2 or 3 or 4 out of 200, it has an exponential change. It's very controversial. We could do a whole separate conversation about it.
Let's start with the next one that we saw that came in during April of this year. I think it was with Humana. So,
yes,
what do we see here?
Okay, totally different audit methodology here. You see a sample size that's much bigger, 1,525. And the reason it had to be bigger to be valid is because they're not just looking at those high error codes, they're looking across all codes. You see a much lower error rate, 13% error. We would normally have an error tolerance in a case like this of anywhere to up to probably 5%. We can talk a little bit more about that later, but here that was 13%. We've got a visual for you. You can kind of see, like, you might look at this and go, okay, not bad. But with extrapolation, and again, extrapolation, not just across a subset of claims, across all claims, that took them quickly up to 197 million. So a
lot of money.
Huge amount that they were demanded back.
Yeah, and I think that we have a breakdown of those errors. So the largest bucket, it looked like, were 166 didn't have records that supported the code. So, either they didn't have a treatment plan, or, the medical record wasn't robust enough to support that code. And that's a huge amount, actually. And then 18, we saw 18 were actually overcoded. They, when the OIG did their audit, after looking at the record, they evaluated that there should have been a lower code. And then 17 had other problems, like it wasn't signed, they couldn't find the record, which is always a bad day. And then interestingly enough, they actually identified that 2 were undercoded, which I think means it was probably a pretty good audit. Most of the time when you do an audit, you're expecting to get both overcodes and also undercodes. But I mean, obviously we want the undercoded to be a little bit more than just a small little sliver, right?
So in this case, obviously there's this huge overpayment. The OIG also recommended that that this particular payer enhance its procedures to detect compliance. They did not make that other recommendation. They did not say, now you need to go into other periods, just for whatever reason. I don't know why, but they did say you have to enhance your compliance program. In this case, the payer vehemently disputed the findings, and there is some controversy about what they made some claims that probably do have some veracity. We're going to see controversy about some of the way that the extrapolation was done. You always have controversy about that. We're going to see some back and forth about when coders disagree. And this is the kind of thing that just makes providers crazy, is that when you're talking about high stakes like this on an extrapolation and you have claims where 2 different coders did not agree, it's very, very challenging to extrapolate in that case. And so we're going to see that get debated. That was an issue in the past with the OIG audits as well. And then there's just some other, just procedural claims that they made. So this is hotly disputed and controversial. This isn't over, in my view.
Yeah, I think we're probably still going to see a large fight ensue on this specific audit. So the last audit that we're going to talk about came in May of 2021 with Anthem. And I believe that this is very similar to what we saw from the February Blue Cross Blue Shield audit.
Yes, very interesting. Same thing, high risk codes. And in this case, the OIG made a statement at the beginning of their summary, and they said most of the sample had errors. Now it's slightly lower than the other one. It was a 60% error rate. I think
still a bad error rate though.
It's not a good error rate. But what was the other one? 75%?
75%, yeah.
Mm-hmm. And you can see here, if you're watching along, we have a graph this came right out of their report. Similar kinds of cases where we have the bucket for acute and then the bucket for not supported by the treatment plan. In this case, the OIG recommended the same as they did in the original one we talked about, where they directed the payer to go back and look at other periods. And they also, said you need to improve your compliance program. The auditee, the payer here, did dispute these findings and objected to, in particular, the idea that they have to go into these other periods and refund. And they objected to the idea that they need to improve their compliance program, among other things.
Yeah. So Wendy, let's summarize, what did we learn from these 3 audits that have been released so far? What should providers know? How should they proceed moving forward?
Well, one of the things that is a takeaway, we like to say it's a good time to be a Village MD. And this applies here because at Village MD, we have, and we are and have at the core of our mission, our providers. And really these codes are used for reimbursement, but that at their core, they're clinical in nature. And so they really need to come from a provider, from a physician or a provider as part of their face-to-face visit, and they're diagnostic. And so the bottom line to all of this is if the diagnosis is correct and accurately describes the patient's condition, for the most part, it's going to be okay. If a physician diagnoses a patient with one of these conditions, they're likely going to be recommending or trying to recommend treatment, because these only become HCC codes because they're likely to be serious and cause, expense. And so, but the core of the compliance here is clinical, really. The other takeaways aren't new, but they're worth repeating, that all providers, payers, whoever is involved in the chain of this, really needs to just make sure they have procedures for audit accuracy. It's recommended that you do audits for these high error codes, and there's different ways to do them. Some of them are easier than others, but going forward, they're going to be they're letting us know that they're expecting us to detect if there's misunderstandings about these codes. Many times it might be somebody wrote acute stroke and they meant to write history of stroke, or, it could be a keying error. And so they're just expecting us to find those. And then the last thing, of course, is it's always good to have an open dialogue with, of course, so that people feel like they can report problems and ask questions. That's a big part of our culture here at Village MD. That's always an important part of compliance with any kind of billing, but especially in this controversial area.
Great. I think that those are important lessons for everyone to take away, and we'll just keep watching these. There's a lot more that's going to unfold throughout 2021. So
Janessa, we have some enhancements to the podcast. Why don't you tell our listeners about those?
Great. Yeah. So, we've had some feedback and we're listening to you and to any of our listeners. So we have made all of our podcasts moving forward will have closed captioning on them to allow for, whatever different listening or watching type that you are. And then we also will have a transcript available on our website, which is vmdworkingsmarter.com. So you can always access our transcript on our website. And then we're also, going to make sure that we're publishing our key takeaways. So if you're interested in bringing something with you, or it's a helpful guide as you're watching or listening, feel free to download that as well. And then obviously we think that this is great, and we hope that all of you enjoy listening. And so we encourage you to like, subscribe, and also we would love a comment on whatever channel or whatever way that you watch or listen to this podcast.
Janessa, thank you so much for joining me today. And like you said, we'll be back with more information as this develops.
Thank you to our sponsor, Village MD. We hope you will join us for future concise compliance conversations.